brain and spinal abscesses. A brain abscess is a free or encapsulated collection of infectious material of brain parenchyma between the dura and the arachnoid linings. Subdural empyema, or between the dura and the skull. Cranial epidural abscess. Spinal abscesses typically occur in the epidural, subdural, and intermedullary regions. Etiology and pathophysiology. A brain abscess is usually a result of direct inoculation of organisms, as from the paranasal sinuses, middle ear, teeth, penetrating brain injury, cranial surgery, or bacteremias from extracranial sources. Example, intracardiac lesions. Staphylococcus aureus is the etiologic agent in 60% of spinal epidural abscesses. Intermedullary abscesses are more common in the pediatric population and are associated with lumbosacral dermal sinuses. Approximately 20 to 30% are cryptic abscesses with no apparent source of infectious seeding. In the initial inoculation period, organisms invade the brain parenchyma, resulting in local inflammation and edema. The resulting cerebritis develops into a necrotic lesion and then becomes encapsulated. Fungal brain abscesses is commonly seen in HIV positive patients and other populations who are immunosuppressed. Diffuse microabscesses may occur with infections caused by Candida species. Mycobacterium tuberculosis may cause abscesses of pus containing acid-fast bacilli, AFB, surrounded by a dense capsule. These abscesses are also found in patients who are HIV positive or have other immunosuppressive diseases. Clinical manifestations. Headache is poorly localized with a dull ache. Increased ICP may result in nausea, vomiting, decreased level of consciousness, LOC. Fever is found in less than 50% of cases. Neurologic findings such as hemisensory and paresis deficits, aphasia, ataxia may be present. Seizures are frequently present. Dental abscess, sinusitis, and otitis media may be present. Backache is the presenting symptom in 94% of patients with spinal epidural abscesses and is a common finding with spinal subdural abscesses. Diagnostic evaluation. CT, MRI with contrast locate the site of abscess, follow evaluation and resolution of suppurative process. On CT scan, early cerebritis present as hypodensity and progressive encapsulation is represented by a hypodense ring around the lesion. There may be decreased ring enhancement with patients who are immunosuppressed, which may be due to a lack of inflammatory response. Microabscesses may not be detected by the CT scan or MRI. Second, blood cultures are obtained to identify organism positive gram stain, leukocytosis, and elevated erythrocyte sedimentation rate, that is ESR. Third, cultures are obtained from the suspected source of infection using stereotaxic needle aspiration or brain surgery to identify the organism and sensitivity to antimicrobials. Number 4. A metastatic brain abscess may be differentiated from a metastatic tumor by CT scan or MRI. Abscesses have hypodense centers with a smooth surrounding capsule, whereas tumors may have irregular borders and diffuse enhancement. Number 5. EEG detects seizure disorders. Obtain history of previous infection, immunosuppression, headache, and related symptoms. Perform neurologic assessment including cranial nerve evaluation, motor and cognitive status. Management. Closed stereotaxic needle biopsy under CT guidance may be used for drainage and evacuation instead of craniotomy. Number 2. Radical surgical debridement, especially with fungal infections, may be indicated with antimicrobial therapy. Number 3. Initiation of empiric antimicrobial therapy is based on gram stain and the suspected site of origin. Because brain abscesses are frequently caused by multiple organisms, antimicrobial therapy is directed toward the most common etiologic agents: streptococci, anaerobic bacteria, that is Bacteroides species. Staphylococcus aureus may be suspected if surgical procedure have been performed. Gram-negative bacteria, example Clostridium species, should be suspected if a cranial wound has been contaminated with soil. Penicillin G, metronidazole and third generation cephalosporins are common therapeutic agents. A 6 to 8 week course of parenteral antibiotics is typical, followed by 2 or 3 month course of oral antimicrobial therapy. Number 4. Antifungal therapy such as amphotericin B is initiated for candidiasis and other fungal infections. Antituberculosis pharmacotherapy such as rifampicin, isoniazid and pyrazinamide should be used to treat abscesses containing acid-fast bacilli (AFB). Adjunctive therapy includes corticosteroids and osmotic diuretics to reduce cerebral edema and anticonvulsants to manage seizures. So first one is needle biopsy, drainage, evacuation of cerebral fluid instead of craniotomy. Second one, radical surgical debridement. Then gram-negative bacteria means these antibiotics, antimicrobials should be given: penicillin G, metronidazole, third generation cephalosporins, and this antimicrobial therapy to be continued for 2 to 3 month course. Antifungal therapy, amphotericin B, antituberculous pharmacotherapy, and last one is corticosteroids, osmotic diuretics. Complications: the brain abscess can rupture into the ventricular space, causing a sudden increase in the severity of patient's headache. This complication is often fatal. Papilledema may occur less than 25% of cases, indicating intracranial hypertension. Lumbar puncture may be dangerous due to the possibility of brainstem herniation. Permanent neurologic deficits such as seizure disorders, visual defects, hemiparesis, and cranial nerve palsies may be present. There is greater mortality if the patient has symptoms of short duration, has severe mental status changes, and has a rapid progression of neurologic impairment. Nursing management can include relieving pain, promoting thought process, minimizing neurologic deficits, and reducing anxiety. Thank you.